I'm discussing with you perioperative consideration for specific lesion. And in this, I would discuss with you right to left shunt, right? All the conditions which comes under right to left shunt, like your TOF, etc. Then your left to right shunt, right? Left to right shunt, like your VSD, ASD, etc. Okay, so we'll discuss that. Then I will discuss with you patient having after Fontaine surgery, Fontaine circulation. So single ventricle Fontaine circulation. So patient with Fontaine circulation, right, which is done as a palliative procedure in single ventricle. So I'll discuss about it. Then we will discuss patients with pulmonary hypertension. Pulmonary hypertension, what important precaution we have to take. Then we will discuss that obstructive lesions, the obstructive valvular diseases, and we will discuss the regurgitant valvular diseases, regurgitant valvular disease. And in the end, I would just mention that post-cardiac transplant patient, what important thing we need to keep in mind. So let's start with right to left shunt. So coming on, right to left shunt, right to left shunting, right? So right to left shunting, which can cause cyanosis because of the mixing of unoxygenated blood with oxygenated blood. So let us first discuss the physiological concept. So let's say these are the 4 chambers of heart. I'm just making it like this: right atrium, left atrium, right ventricle, left ventricle, and we have connection between right to left side, right to left side. Okay, so what can happen if this is the connection? What is mixing? The deoxygenated blood is mixing with your oxygenated blood. So deoxygenated blood and oxygenated blood is mixing. This is the parallel kind of circulation. To minimize the mixing of deoxygenated with oxygenated blood, we need to maintain the left atrial and diastolic pressure. If there would be higher left-sided end diastolic pressure, then definitely the shunt fraction will decrease. Then we need to maintain the right atrial pressure, the right side pressure. If right side pressure will increase, as in pulmonary hypertension and all, again the shunt fraction will increase. So we have to decrease this gradient. We have to decrease the gradient between right and left side by maintaining the left atrial pressure and by minimizing the right side pressure, right? So remember, we need to avoid peripheral vasodilatation in these patients. Peripheral vasodilatation. So what will happen in peripheral vasodilatation? The peripheral vasodilatation will decrease the preload, and decrease in the preload will decrease left ventricle end diastolic pressure and left atrial pressure. When this side the pressure will decrease, what will happen? The shunt fraction will increase. So this will increase shunt fraction. So when the shunt fraction will increase, more and more oxygenated and deoxygenated blood will mix, and patient will have cyanosis and decrease in saturation, decrease SpO2 we will see. Okay, so we have to avoid decrease in SVR. So first thing which we need to avoid is the decrease in SVR. We need to avoid the systemic vasodilatation. Now second thing which we need to avoid according to the physiological concept. So we need to avoid increase in pulmonary vascular resistance. So avoid increase in pulmonary vascular resistance. What will happen? The right side pressure will increase, and again it will cause the same thing. It will increase shunt fraction, and when shunt fraction will increase, same thing, cyanosis and decrease in the saturation will happen. So what are the hemodynamic goals we have to? So what we need to avoid? Decrease in SVR, and we need to avoid increase in pulmonary vascular resistance. So what are our hemodynamic goals? The hemodynamic goals is to maintain the blood pressure and maintain the pulmonary vascular resistance or decrease the pulmonary vascular resistance. So the hemodynamic goal is maintain the blood pressure, maintain the blood pressure, right? Maintain the SVR of the patient and decrease the pulmonary vascular resistance if it is possible, right? So we need to avoid decrease in SVR, avoid increase in SVR. So what intervention we will take to do this? So to avoid decrease in SVR, we need to, you give our patient the vasoconstrictor if required. We need to maintain the euvolemia. So first thing we need to do, we need to maintain euvolemia. We need to maintain proper preload, euvolemia. Then we need to give vasoconstrictor if the vasodilatation is happening, vasoconstrictor. Now here, what vasoconstrictor would be best? The best vasoconstrictor would be vasopressin. Why vasopressin? Because vasopressin increase systemic vascular resistance and it has no effect on pulmonary vascular resistance. So vasopressin increases systemic vascular resistance, increases SVR and has no effect on PVR. So this is better than phenylephrine. Phenylephrine would increase both SVR and PVR. Here PVR is not affected, only SVR is increased. So vasopressin would be the best for right to left shunt. So we have discussed for right to left shunting, vasopressin would be the best vasopressor, and for right to left shunting, we need to maintain the blood pressure of the patient and we need to maintain the PVR, or we need to decrease the pulmonary vascular resistance. Okay. Now to decrease the pulmonary vascular resistance and prevent the increase in pulmonary vascular resistance, we need to avoid hypoxia, hypercapnia, acidosis, hypothermia in the patient. So avoid hypoxia. So ventilation should be properly managed. Avoid hypercapnia, acidosis and sympathetic stimulation. Okay. Now what else we need to take care in these patients? So we have to maintain the systemic pressures. So when we have to maintain the systemic blood pressure of the patient, we need to have a very let's say good watch on the blood pressure of the patient. So invasive blood pressure monitoring should always be attached prior to induction. So what note I want to put in here, that invasive monitoring before induction, because induction is one time when we are giving the agents which decreases SVR. So we have to go for invasive monitoring. So you can go for invasive monitoring and you can use your drug wisely. The drug which would not affect the SVR more, like ketamine, etomidate, etc., which I will discuss further. So invasive monitoring, and we need to take all precaution for air embolism. So we have to take all the precaution to prevent air embolism, because there is a risk of paradoxical embolism and infarct to happen in these patients because of the shunt between right to left side, connection between right to left side. So any air would be embolized in the pulmonary circulation, can go into the systemic circulation and can cause infarct in these patients. So we need to avoid paradoxical embolism to happen, taking proper precaution by de-airing, etc. So we'll talk about de-airing in our management. So this is what we have to do in right to left shunt. So again revising, in right to left shunt, we need to prevent mixing of oxygenated and deoxygenated blood. To prevent this, we need to increase the left side pressure and we need to decrease the right side pressure, because what is happening, blood from right side, that is deoxygenated, is going into the left side. So what we do, we maintain the systemic pressure and we decrease the pulmonary vascular resistance, right? So any increase in pulmonary vascular resistance or decrease in SVR can increase cyanosis in these patients. So we have to remember this would be our hemodynamic goal. Maintain SVR, decrease PVR. Okay. Now coming on the next is left to right shunt. Now left to right shunt compared to the other cardiac lesion are easier to manage. They are easier to manage, right? So left to right shunt, left to right shunt. So what happens in left to right shunt? So again, this is, let's say, the 4 chambers of heart, that is right atrium, right ventricle, left ventricle. So left to right shunt, that is like this. The shunt is between left atrium to right atrium or left ventricle or right ventricle. So left to right shunt. So what happens in left to right shunt? In left to right shunt, oxygenated blood is going into the right side. Mixing is happening. Mixing of oxygenated and deoxygenated blood is happening. So in this, what should be our goal? We need to maintain or decrease the SVR. The left-sided pressure should be little decreased, because if left-sided pressure will increase, what will happen? More and more blood will get wasted and it will go and mix in the deoxygenated chamber of the heart. So, increase systemic vascular resistance, increase left-sided pressure would increase left to right shunt. So, we need to minimize the systemic pressure in these patients, just opposite to right to left shunt. And same thing, right atrial, the PVR, the pulmonary vascular resistance, we should not cause any decrease in pulmonary vascular resistance. If pulmonary vascular resistance will decrease, what will happen? Again, the shunt fraction will increase. So what will happen? In left to right shunt, more QP-QS ratio. So if pulmonary blood flow is much higher than systemic blood flow, this will cause the pulmonary congestion. And this pulmonary congestion will produce the symptoms like dyspnea, failure to thrive, etc. So it will cause the increased burden on the pulmonary system. Pulmonary vascular resistance would increase and pulmonary pressures would increase. So it can cause dyspnea, it can cause failure to thrive in the patient, especially in pediatric, failure to thrive, right? So we need to avoid this pulmonary congestion. So what is our hemodynamic goal? Hemodynamic goal is to maintain or decrease systemic vascular resistance. What should we avoid? Avoid decrease in pulmonary vascular resistance. So to avoid decrease in pulmonary vascular resistance, what should we do? We should avoid hyperoxia. Increased oxygen concentration decreases PVR in a most effective way. So avoid hyperoxia and hypocarbia. So how can we do this? By decreasing the FiO2, by keeping a low FiO2 and decreasing hyperventilation, right? Hyperventilation, decreasing minute ventilation. So we need to keep the CO2 towards little higher side and oxygen towards little lower side, just opposite what we were doing in the right to left shunt. Okay, so here we need to prevent the shunt fraction, right? We need to prevent the shunt fraction to increase, and this can be prevented simply by preventing the decrease in PVR and by decreasing the SVR to some extent. So goal is to decrease or maintain SVR and prevent the decrease in PVR. Okay, then you put a patient on mechanical ventilation. Now mechanical ventilation, when a patient is on, it would decrease the systemic vascular resistance also, and it decreases the pulmonary vascular resistance also. The overall effect of mechanical ventilation is something which cannot be commented on, what it will actually produce. So it is difficult to predict. So effect of mechanical ventilation, difficult to predict. Why? Because they decrease SVR and they decrease PVR also. Okay. Okay. Next is, we will discuss about Fontan physiology or cavopulmonary palliative shunt, right, which is done in single ventricle. So Fontan physiology. Fontaine physiology, or cavo-pulmonary palliation, what we do, that is shunt between pulmonary artery and vena cavas. Okay, so to maintain a series circulation in patient with single ventricle. So what happens in single ventricle pathologies? In single ventricle pathology, whatever ventricle is there, right or left, it will pump the blood into the aorta and it will go in the systemic circulation. And how would the blood return to heart? It will return through the pulmonary arteries. So there is a shunt created between superior and inferior vena cava and pulmonary artery, so that the blood returns into the heart through pulmonary arteries. This is the Fontaine physiology. And how much is the pulmonary blood flow? It depends upon your transpulmonary gradient, the gradient between the pulmonary pressures and your left ventricular end-diastolic pressure, left atrial end-diastolic pressure. So transpulmonary gradient, right? So we will talk about all those things. So what is the hemodynamic goal in Fontaine physiology? But before discussing the hemodynamic goal, let us discuss the physiological concept. So pulmonary blood flow, as I said, the pulmonary blood flow depends upon the right atrial pressure, not right ventricle, right atrial pressure, and it depends upon the pulmonary vascular resistance. So pulmonary blood flow depends on right atrial pressure and on low pulmonary vascular resistance. So we have to keep the PVR as low as possible and we have to maintain the right atrial pressure. So on this transpulmonary gradient, your pulmonary blood flow depends, right? Then we need to maintain the myocardial contractility in these patients, right? Because single ventricle, if myocardial contractility is decreased, what will happen? Performance will decrease and this will increase the atrial pressure. So it will increase this atrial pressure. So myocardial depression may reduce single ventricle performance, and this can cause increased common arterial pressure, common atrial pressure. So increase in common atrial pressure because of myocardial depression can be seen, right? So what is our hemodynamic goal? We need to decrease the PVR as much as possible to maintain the pulmonary blood flow. So decrease pulmonary vascular resistance and to maintain the myocardial contractility and maintain myocardial contractility. Now remember, in this we need to maintain the preload, right? So we have to avoid any increase in PVR, and we need to let's say avoid hypovolemia, and we have to avoid myocardial depression, right? So we need to maintain preload, right? Maintain the preload. Okay. So to prevent the increase in PVR, hypoxia, hypercapnia should be avoided. Hypoxia, hypercapnia avoided. Any sympathetic stimulation avoided. Then we need to maintain the volume. So volume can be given, and any drug which is causing the myocardial depression should be avoided. So this is the thing we have to practice in Fontaine physiology. 3 things we have to practice in Fontaine physiology. Number 1, we need to maintain the, we need to decrease the PVR or maintain the PVR. We need to decrease the PVR because more the gradient between the left atrial pressure and pulmonary vascular system. Mode will be the pulmonary blood flow. So PVR should be decreased. To decrease PVR, hypoxia, hypercapnia, acidosis, sympathetic stimulation should be avoided. We need to maintain the preload. We need to, because then only the ventricle will let's say contract and perfusion will be maintained. And we need to maintain the contractility of ventricle, because if contractility of ventricle decreases, then both right and left atrial pressure, biatrial pressure will increase, and there would be problem of increase in biatrial pressure. So we need to maintain the contractility, we need to maintain the preload, and we need to decrease the PVR, okay, in your Fontaine physiology. So this is the image of Fontaine correction done in single ventricle. So right ventricle is hypoplastic, left ventricle is mostly doing the job, single circulation in series has been maintained. Left ventricle pumps the blood, it goes into the aorta to the systemic circulation. The blood returns to the heart through what? Through the anastomosis between inferior and superior vena cava with pulmonary artery, and through pulmonary artery it goes into the lung. So it is going into the lung where it will get oxygenated. Okay, so blood is returning to the heart, to the left side of the heart through the pulmonary veins, and this is depending upon the pressure gradient. This return depends upon the pressure gradient. So how much blood will flow into the lungs, into pulmonary blood flow, it will depend upon the pulmonary vascular resistance, and it also depends upon the left atrial pressure. Greater the transpulmonary gradient, less blood will flow in the pulmonary vasculature. So we have to keep the left sided pressure less, we have to decrease the pulmonary vascular resistance, we have to keep the left atrial pressures less, we have to maintain the preload, right? We have to maintain the preload, and we have to maintain the contractility of the ventricles. So this is Fontaine physiology. As you can see, inferior vena cava and superior vena cava is anastomosed with pulmonary artery, and the circulation is in series. It is not a parallel circulation. Okay. Next, which I want to discuss with you is patient with pulmonary hypertension. Now these are the patient which we have to take a lot of care in management. So pulmonary hypertension. So when a patient has a pulmonary hypertension, not much we can do to decrease the pulmonary pressures. What we can do, we can prevent any more increase in the pulmonary vascular resistance. So any increase in PVR should be avoided. So anything which increases the PVR, like hypoxia, hypercapnia, acidosis, etc., should be avoided, of course. Then there are drugs which can decrease the PVR. If possible, we can use it in the intra-op period. So what we have to do is we don't have to let the PVR to increase. So don't let pulmonary vascular resistance to increase further, right? Lower pulmonary vascular resistance as much as possible. So what can lower the pulmonary vascular resistance? Your inhalational anesthetic agents. Inhalational anesthetic can lower the pulmonary vascular resistance. Mechanical ventilation can lower the pulmonary vascular resistance. High FiO2 can lower the pulmonary vascular resistance, and low PaCO2. Hyperventilation can lower the pulmonary vascular resistance. Okay, so what is our goal? What is our goal in our pulmonary hypertension? So we have to decrease PVR, we have to maintain preload. We have to maintain the preload. What we have to avoid? Any increase in PVR and avoid hypovolemia. So avoid increase in pulmonary vascular resistance, avoid hypovolemia, avoid hypovolemia. So what are the interventions which could be done? So avoid increase in PVR. So we can use the pre-op, we continue the pre-op medication, which is used to decrease PVR. Then as I said, avoid hypoxia, avoid hypercapnia, and we need to consider the inhaled pulmonary vasodilator like your epoprostenol, etc. So consider inhaled pulmonary vasodilator, right? Pulmonary vasodilator. So what is the main important goal in pulmonary hypertension? So what is goal in pulmonary hypertension? Goal in pulmonary hypertension is to maintain the pulmonary vascular resistance or try ways to decrease it if possible and maintain the preload of the patient. So once again, let us see what are the ways to decrease the pulmonary vascular resistance. So how can I decrease the pulmonary vascular resistance? Hyperoxia is one of the potent pulmonary vasodilators. So administer high FiO2 and decrease the CO2, hyperoxia and hypocarbia. Avoid sympathetic stimulation by smooth anesthesia, preventing pain, preventing hypovolemia, etc. So smooth anesthesia without coughing, etc. Proper analgesia throughout the perioperative period. Sympathetic stimulation would increase the PVR. Then treating the perioperative increase in PVR do not appear to be due to, let's say, hypoxemia, hypercarbia or thromboembolism, right? What we should do, that there's a possibility we can use inhaled nitric oxide, we can use inhaled iloprost or treprostinil. These are the drugs which can be used. So PVR is increasing and it's not hypoxia, it is not hypercapnia, even hyperoxia is not preventing it to increase, even hypocapnia is not preventing, there is no sympathetic stimulation. Then we can use pulmonary vasodilator like inhaled nitric oxide, 20 parts per million, and we can use inhaled iloprost or treprostinil, these drugs, whichever is available, right? Whichever is available at your centers, right? So these are the ways to decrease the PVR. Maintain adequate preload. This is the second thing which we need to do. So how do we maintain the preload? You know, you cannot give too much of fluid also in patient with pulmonary hypertension. The risk of pulmonary congestion is always there. So avoid hypovolemia, whether absolute due to blood loss or relative due to vasodilatation, due to anesthetic agent. CVP measurement, if possible, we can use the central venous pressure monitoring, and what we do, we try to maintain the CVP near the baseline. If hypovolemia with right ventricular underfilling, we can give the fluids gradually, right, in the incremental dose. If you give fluid very fast, there is a risk of pulmonary congestion also developing. So 5 ml per kg increment of isotonic crystalloid to increase the intravascular volume, right? Hypervolemia is also avoided because overload can cause right ventricular distension, pulmonary congestion, and it can worsen any regurgitation if the patient is having tricuspid regurgitation, etc. So pulmonary hypertension, if patient of pulmonary hypertension is for surgery, we need to maintain the preload, we need to maintain the euvolemia, neither hypo nor hypervolemia, right? Hypovolemia would decrease the preload, it's preload dependent condition, and hypervolemia can cause pulmonary congestion, right? And we need to maintain the PVR, we need to decrease the PVR, we need to keep the FiO2 high, we need to hyperventilate the patient, right? So these things we have to remember, okay? Now let us talk about the other type of lesion. Let us talk about obstructive lesion. Obstructive lesion. So obstructive lesion, that is fixed cardiac output lesion, like your mitral stenosis, tricuspid stenosis, aortic stenosis. Now these lesions, the stroke volume is fixed. It depends upon the gradient between the two chambers of the heart, two chambers. So this is the lesion with stroke volume fixed, stroke volume fixed. Now decrease systemic vascular resistance. If for any reason SVR decreases, absolute decrease in SVR because of blood loss, etc., or relative decrease in SVR because of anesthetic agent, any decrease in SVR happens, then because of the fixed stroke volume, compensatory increase in cardiac output will not happen and peripheral perfusion will get affected. So if decrease in SVR, it will cause hypotension, and this, as the stroke volume is fixed, so cannot compensate, compensate adequately to increase the cardiac output. So what will happen? The peripheral perfusion will get affected. Now let's say in mitral stenosis or mitral valve or tricuspid valve stenosis, in these two, how to maintain the left ventricle filling pressure, how to maintain the cardiac output? Heart rate we can keep towards the lower side. So decrease heart rate is beneficial. Decrease heart rate is beneficial. So what will this do? It will give more time to the diastole and more filling of the ventricle will happen, right? So we have to decrease the heart rate. By this will give the long diastolic period, and we need to maintain the sinus rhythm, right? Sinus rhythm, because this will lead to atrial contribution in the ventricular end diastolic volume, in the ventricular filling. So if sinus rhythm is there, atria would contract. The last, let's say, contribution of atria in the ventricular filling will not be removed. So sinus rhythm and decreased heart rate would be very, very beneficial. And in aortic stenosis and pulmonary stenosis, decreased heart rate would reduce the work of the myocardial work, myocardial oxygen demand, and it will be also beneficial. So in obstructive lesion, increase in heart rate should be totally avoided. What I said, that in aortic stenosis and pulmonary stenosis, decrease in heart rate decreases myocardial oxygen requirement, right? So when this happens, again the myocardial oxygen demand decreases. It allows more time for the ventricle filling to happen. It also allows more diastole time, and it will also increase the ejection fraction. So always we need to keep the heart rate towards the lower side. So tachycardia and hypotension both has to be avoided. Hypotension has to be avoided because fixed cardiac output lesion depends upon the blood pressure for the perfusion, because cardiac output may be compensatory, not increase because of fixed stroke volume. And to increase the stroke volume, what we can do? We can increase the diastole time. So that can be increased with the help of decreasing in heart rate, bradycardia. So tachycardia and hypotension has to be avoided. So what is the hemodynamic goal in obstructive lesion? So first, heart rate should be towards the lower side. Sinus rhythm has to be maintained. Blood pressure has to be maintained. Adequate preload, right, should be there. So number one, sinus rhythm. Number two, the heart rate either decrease or towards normal. Then preload adequate, and then SVR maintained. The blood pressure should be maintained. The vasoconstriction should be maintained. What should we avoid? Avoid tachycardia, avoid hypovolemia, avoid hypovolemia. And what intervention? Well, how do I avoid tachycardia? We can use the drug which can decrease the heart rate, or we can use the pharmacological cardioversion, and we can go for electrocardioversion, right? We can go for pharmacological decrease in heart rate by giving some medications to the patient, or we can go for electric cardioversion to decrease the heart rate. So avoid tachycardia. So if heart rate is increasing, right, we can go for drugs which decreases the heart rate, or we can go for cardioversion, right? Hypovolemia is avoided by maintaining euvolemia, IV volume status. So we should maintain the volume status of the patient. So this is what we do in obstructive lesion, mitral stenosis, tricuspid stenosis, aortic stenosis, or pulmonary stenosis. Avoid tachy, avoid hypotension, maintain preload, and maintain the sinus rhythm of the patient. Okay. Now coming on the regurgitant lesion. So regurgitant lesion, what we need to do? We have to maintain the perfusion. We have to decrease the regurgitants, right? So what do we do? To maintain the perfusion, we need to decrease the SVR, just opposite to what obstructive lesion requires. So in regurgitant lesion, right? We need to maintain the heart rate or increase the heart rate, the hemodynamic goal. Why? Because we have to maintain the forward flow of blood. So impedance to the blood should be decreased. So lower the impedance forward. So vasodilatation will help. Lower the impedance, vasodilatation will help. Okay. And if there is decrease in heart rate, the diastolic time will increase and regurgitation fraction would increase. So aortic and pulmonary, right? Aortic and pulmonary regurgitation increases if diastolic period will increase. If diastolic time period increases. If diastolic time period increases, right? So if diastolic period increases. So hypotension and tachycardia, or maintain the heart rate if not tachycardia. So normal or increase heart rate and decrease SVR. So avoid decrease in heart rate, avoid hypertension. Okay. How do we do this? Avoid decrease in heart rate. We can give anticholinergic drug. If heart rate is decreasing, immediately treat with anticholinergic drug. So anticholinergic drug like glycopyrrolate or atropine, and avoid hypertension. If required, vasodilator should be used. So again I will explain. In regurgitant lesions, we need to maintain the forward flow, we need to decrease the regurgitant fraction. How do we do this? To maintain the forward flow, we decrease the impedance to the flow by decreasing the systemic vascular resistance. So forward flow will increase, and we try to decrease the diastole time or maintain the diastole time. We shouldn't increase the diastole time, because that is the time in which the regurgitant fraction increases, especially for aortic and pulmonary regurgitation. So what is the target? We need to prevent brady, we need to prevent hypertension. And so any intervention we have to do immediately if heart rate is decreasing or if blood pressure is increasing. So vasodilator and anticholinergic drug should be in our hand. So this is how we manage the regurgitant lesions. Now